So waiting on our Facebook audience to come in. As soon as they come in, we want them to like and share the video. Are you going live on your phone? No. Okay.
That's too much for me. I'll finish. I just add it to my timeline. So I have to add it, you know.
Okay.
I was getting so much fun, but I had to put some controls. Oh my God. Oh my God. Okay, let me see if I can invite some more people in here.
Oh, did I not go that way? I need to start.
Okay, let's see.
I wish that there was a way that it would go live on all the social medias.
Yeah.
That would be just so perfect. One of these days they'll get it together. Yeah.
Individual like that.
You have to invite individuals.
Oh,
So
great.
It'd be always.
I'm sure.
Yeah, we do. If I tagged you in it, so it should appear on your page unless you have to answer. Do you have to approve yours?
Yeah.
Okay, so when you get a chance.
Right.
Okay. Hey, Whit. Hey, you guys. Hey, Diana. Hey, Henry. Hey, Robert. Thank you guys for tuning in. Can you please like and share the video? Like and share the video. Okay, he's waiting on me. All right. My two favorite people. That must be Diana. Yeah, Diana said hi to my two favorite people. Hi. Hello, hello. Welcome to Warriors Talk with Lady ReShell, where we move away from awareness towards action on this Motivational Monday. And as always, I'm so excited you have chosen to tune in today. We have a very special guest, and our topic is going to give you some information that you can use to help lower your risk of cancer, maybe even save your life. We're going to be talking about what Black women need to know about cancer. So if you're listening on Facebook or Instagram, I encourage you to share this video, like this video, and invite others in on the video. This show is actually being sponsored by Mary Kay with Gloria Dotson. She is catering to all of your beauty needs from head to toe. You can contact her at 773-889-1853. I want you to stay connected with me on all forms of social media. I'm on Instagram, Periscope, Twitter, Facebook. Just type in @WarriorsTalk1. I encourage you to also follow me on YouTube. Follow me on YouTube. What I do is I go around to different events in the community and I bring back information about different diseases, the updated information all about health and wellness so that we can be on top of our health and take action. You can always call in at 773-754-4333. And guess what? We would love to hear from you. This show, since it's Breast Cancer Awareness Month, we are going to be supporting the fighters, admiring the survivors, honoring the taken, and never ever giving up hope. Our healing verse is coming from James 5:14 and 15. And it reads, "Is any among you sick? Let him call for the elders of the church, and let them pray over him, anointing him with oil in the name of the Lord." Amen. And my very special guest today she's an amazing woman. She's a registered nurse. She's also a Zoomer instructor. She's all about health and wellness. She's an advocate, and not only on her job, but in the community as well. And she's here to give us some information about Black women and breast cancer. And so, like I said, if you are just tuning in, share this show with all the women in your life that you love so they can get this valuable information. So I'm going to let my special guest just give you a little information about who she is and why she's so passionate about this subject.
Hi, thanks for having me. My name is Donna Christian-Harris. So I'm an advanced practice nurse practitioner. I work in surgical oncology. I've worked there about 15 years as a nurse for about 31 years. And my passion about this subject is I know that early detection really does save lives. The sooner we diagnose, we can begin treatment and put you on the road to recovery and survivorship. So that's where my passion lies. I've seen patients come in hysterical about what's next. How am I going to continue to work, raise my children, continue to be in a relationship, survive this cancer, and move on to the next step? And I've seen women survive this disease, and so that's where my passion lies. Just being able to give as much information as I can to empower you to take action.
Wow, I like that. She used my word, take action. And so it's so many reports going on, Donna, about African Americans and breast cancer. So when I think about African American and breast cancer, I think about the mortality rate being so high with us. The survival rate is low. And I think about, even though the incidence of breast cancer, our numbers are not high, but for some reason, we are losing the battle to this disease. And I just want to know, what are we doing wrong? What are we not doing? What are we not getting? What is it that we can do, that we can control, so that we can have a better outcome with this disease?
So just a little background, and you've touched on that already, but we know that over 41% of African Americans who are diagnosed with breast cancer, they die from it. The incidence is lower for us, meaning white and other women get breast cancer more often, but our mortality is worse. And a lot of that has to do with the advanced stage upon presentation. If you present and the cancer is already a higher stage, is in the lymph nodes, or it's metastasized to other parts of your body, of course that increases your mortality. The younger age of diagnosis, most younger women or African women who are diagnosed with breast cancer is with a triple negative or an inflammatory breast cancer, which can be an advanced disease as well. So the increase in the size of the tumor. The other thing in African Americans, the incidence with male breast cancer is higher in African American women. So, I'm sorry, in African American men, we have it more often than white men, and the risk can be higher. So, some of the things that we want to look at is, what is it? We look at, is it socioeconomic? Is it environmental? Is it the tumor biology? That's what we're finding out. The type of cells that are in your cancer different from another person's cancer. So the tumor biology and the genetics. Now, most breast cancers are only 15% genetic, but younger women and those who have a strong family history, there's a likelihood that you may have a gene mutation. So environmental exposures, and then some relationship with your diet and nutrition. We also know that women of color, they may come from uninsured backgrounds where they don't have insurance at the time that they're feeling something. They may be below poverty level, and if they're above 19, there's a disproportionate group that are unemployed. So we know those things can be factors. So what are some things that we can do?
Yes.
To control this? Number one, you want to know your risk. Ask your mother, your aunts, your cousins, your family about their cancer history. In the early days, it was taboo to talk about if anybody had cancer. But if you ask the questions and ask them, did anyone have cancer in my family? And if they did, if there's a strong family history, especially in first-degree relatives, that you can be seen by a genetic counselor to find out if you're at risk and if you should get genetic testing. And if the testing is positive, we can do more proactive screening to catch the cancer early.
Right. And the genetic testing, because people may not know exactly what that is. Like, okay, what are they going to be doing to me? It's just a blood test.
It's a blood test. There is a test we could do with saliva, but it can maybe not be as accurate, or you may not have given enough, they may not get enough cells. So the blood test is like the standard of care. A blood test, and it can take anywhere from 7 to 14 days to come back, depending on how many genes they're testing.
Yes.
We have the basic BRCA1 and 2, but we also do panels of genes, P53, check 2. There are other genes that we can test too, because you may have a risk of colon cancer or another type of cancer. So the genetic counselor will be able to, and your provider could choose the best test for you, depending on your family history.
Okay.
So some other things we can control is our lifestyle. So with dietary intake, you want to know what your BMI is, what should be your weight for your height and body type. Try to get in at least 150 minutes of exercise per week. Now, I know that sounds like a whole lot when you think about 150. Start at what's comfortable for you. It could just be walking for 15 minutes every day. It could be getting on a treadmill. It could be counting your steps. The American Heart Association says that we should do about 10,000 steps a day.
Yes.
But if I'm just starting out, if you do 5,000 steps a day, that's fine. Increase your activity. Become physically fit. Look at the Mediterranean diet, which is a diet that's low in fat. It's less red meat. It's more fruits and vegetables and grains and limited alcohol intake. So we advocate no more than 3.5 alcoholic beverages per week to decrease your risk of breast cancer and to decrease and increase your survival if you've had breast cancer.
Yeah.
Those are things you can take control of. And if
Well, you know what? I was thinking about, because I did a presentation at my church yesterday, and we talked about how the research says 60% of the African American women are overweight. And I think that we look at each other all the time, so we think that it's normal because we look normal to each other because we see each other all the time. When in actuality, we are overweight. And so I had this opportunity to present it to me back in August to go through this. I hate to say diet, but it was a diet change. But it was also a lifestyle change to where we ate only fruits and vegetables. And so in the morning we did a smoothie. And it could be fruits, it could be vegetables. And then for lunch, we did a G-bomb salad. So you had greens, beans, onions, mushrooms, and seeds. The salad could be as big as you wanted it to be. And then for dinner, we had like a 3-course meal. So for those who ate meat, I don't eat meat. So for those who ate meat, you eat the normal size. And I was able to lose about 15 pounds within that 30 days. So I know that it can be done if you're disciplined enough to do it. It depends on how bad you want it. And
so you just have to look at your likes and dislikes and just start making some decisions and making better choices. You may need to consult a dietitian to kind of help you to learn how to log your foods and understand what foods are and how to choose foods correctly. We go to the grocery store, and I always tell my patients, try to shop in the exterior part of the grocery store, around the edges, because in the middle is where you have all the cans of the processed foods. So around the edges, you have your fruits and your vegetables and your lean meats. If you eat meat, you have your grains, you have your poultry, your dairy. Think about it. All those things are around the exterior of the grocery store. Take baby steps. If you're able to download some of the apps that we have, they're free apps. You have the MyFitnessPal. That's a wonderful app that allows you to log in your foods and your exercise. There's also the Lose It app. If you're able to spend a little money, you can potentially join Weight Watchers, and they have an app. But there are a lot of tools out there to help guide you and just make small steps. So I could say, okay, so I'm not going to drink sugary drinks. I'm going to give up sugary drinks. I'll do some water and add a little honey and some lemons. Oh, I got lemonade. So as opposed to pop or a sugary juice. Baby steps. If I go to McDonald's, oh my God, I really want a hamburger. Okay, so I'll get the hamburger and I'll get the leaf lettuce, and I say no cheese, no mayo. Get all the lettuce and tomato, no French fries. But if I really, really want something special, then I might just get, a little small shake. But I'm not going to eat the bread. I'm going to wrap my sandwich in the lettuce. So it's baby steps. So you have to find out what works for you. Just small little changes like that can really make a difference. You'll feel better. You'll start to lose weight, and it'll become a part of your lifestyle.
I like that. And when you make it a lifestyle, it's easier to maintain, and you're not really depriving yourself. You don't feel like you're depriving yourself of anything because you're learning how to eat a balanced meal, a balanced diet daily. But so as I think about African Americans and breast cancer, for women hearing about it, after I did the presentation, everybody was like, spooked, because the information kind of scares you. When you hear that we have a high mortality rate, it makes you maybe not want to go in and see what's going on with you. And so we want to help remove some of the fears that individuals have to give them a peace of mind that, once you go in, you have the opportunity, like you said earlier, the earlier you get in, the earlier the stages are, you have an opportunity to have more options to do other things.
Correct. We talk about what are some of the things that add to delay. So why is the morbidity worse if there's delay in treatment? So if I get diagnosed and 30 days has passed and I have not had any treatment, that is delay of care. That is delay of care because those tumor cells have had a chance to potentially move into my lymphatic system and my lymph nodes and potentially spread to other parts of my body, my brain, my liver, my bone. What is the biggest reason there's delay of treatment? Number one, I don't think it's even health insurance. It's fear. Fear that I'll have cancer, I'll die. I'm thinking about Miss Thomas who had cancer. She went through that dreadful chemotherapy. She couldn't eat. She lost weight. Her husband left her. Her partner left her. She lost her job. She couldn't afford to take care of her children. All of those things are going through their mind. So it's very important that if you know someone and they haven't had their screening mammogram or you notice something different, they've all of a sudden lost a lot of weight or they're fatigued, there's a change in their presentation, grab them by the hand and accompany them to the doctor to get examined, to get checked out, because a lot of times they're just so afraid and don't even want to ask for help. So fear is huge, and we definitely know that can add to the morbidity.
I read something that talked about the mental part of it being how someone that's depressed, their mortality rate is higher than someone who's not depressed going through. So that plays a role too. If you add that fear into it, that fear of depression goes along right through the fear. And so how can we, other than grabbing that person by the hand and say, let's go, what are some other things that we could do? Not just for them and for ourselves as well.
Right. It's tough because I think everyone may have an element of feeling sad or depressed or just not their best day, just with life, just living life. Just having an open dialogue with that person, not being judgmental, allowing them to just express themselves and just being a good listener, and not comparing them to other people who you've known have experienced cancer, or because everyone's tumor is different. The treatment plan is going to be based on that individual person. Even if it's the same type of cancer, the treatment may be different. It's going to be based on the individual tumor biology. We have so much information about how to treat the cells of that person's cancer versus the other person, and we look at a lot of other factors. So I just think being a good listener and not saying, oh, when is your doctor's appointment or whatever, just being an advocate. I'm going to pick you up at 2:00. I've prepared some lunch for you. Reaching out and encouraging people to reach out to the employment health services. They have employee support services that are available for counseling, psychological counseling, encouraging patients to complete that family medical leave paperwork so that their jobs can be protected. As a provider, it is our job to complete the paperwork that's needed to protect the patient's job. That is very, very important. Many patients who present where the tumor has eroded through their skin, so you don't see a nipple, there's no areola, the breast tissue is gone, it's just a lump of foul-smelling tissue because the cancer is eroded through. Most times in those situations, there is an element of mental health there. They've had depression, schizophrenia, or whatever, and getting this disease has just crippled them even more. So being a good listener, an advocate, encouraging them, helping them, being able to physically go with them to an appointment or offering to make a meal in that way, and encouraging them to seek psychological help.
Wow. Having a cancer diagnosis can be overwhelming.
Yes.
It can be overwhelming. So any way, like you said, that you can be there for that person, be there for that person. And a lot of times we tend to say the wrong thing, but like she said, just be present. Sometimes you don't have to say anything. just be company, just be there so they can have a peace of mind. Sometimes they don't want to be by themselves, but then they don't want to be around people because they don't want to have to keep answering questions and reliving this fear over in their mind. So sometimes they just want to have company.
The really great resources for patients is our support groups. We have wonderful support groups. We have the American Cancer Society, they have a 24-hour hotline. There's Susan G. Komen. There's Sisters Working It Out. There's Sisters Network. There's Breast Cancer 360.
Wow.
We have the NCCN guidelines that you can look at as a patient to know, am I receiving the appropriate care for my cancer? The other thing is we get a lot of second and third opinions. Anything more than a third opinion, that is delay of care.
Wow.
So you have to make a decision, commit to treatment, and follow through. We have patients diagnosed in June. This is October, and I'm going for another opinion. That's fear, and that's delay of care. Commit to where you're going to be treated and get the treatment. It's okay to get a second opinion, but a third and a fourth is delay of treatment. And that could also negatively affect your outcome.
I totally agree because I found my mom November 1st, so this November would be 5 years for me. And it was actually confirmed, so they got me in right away. When I told my doctor, they got me in right away. And once I did the biopsy and everything, it was confirmed December 18th. But by the time I went December 18th, another tumor had appeared. Like I had 2 more, so it was like 3 altogether. So if I had waited, if I had delayed it, because mine was aggressive, and so if I had waited, who knows where I would be, if I would be sitting here right now. So I totally agree with once you find it. And it's funny because when I found it, it wasn't like, ooh, okay, this may be cancer. In the back of my mind, it could be because I had a sister that passed away from it.
Okay.
But I didn't allow it to paralyze me.
Right.
I was just like, you know what, I'm just going to make this appointment. I'm just going to go and see what it is. And so that's what I did. Now, if I really had sat and thought about it, I probably would have been like, okay, this could be. But I didn't give it time to play in my mind and all these different scenarios. I just didn't let it set in my mind.
Yes. And then younger women who find a lump, most are not cancer. It can be a benign fluid-filled cyst or fibroadenoma or something that's benign. But we've had women in their early 20s to get diagnosed with breast cancer and not even have family history. So what I'm saying is you feel something new or different in your breast, go see your healthcare provider so that you can get the proper workup, examination, imaging, and potentially a biopsy, depending on what the findings are from the imaging. Don't think, oh, it's nothing or it may go away. If it presents like an infection, so it's warm, it's red, it's swollen, it's hot, it may be an abscess, but get an exam, have it worked up by a healthcare provider, a breast specialist, so that we can rule out if it's an inflammatory breast cancer, which can be a very aggressive type of breast cancer. So when in doubt, call your healthcare provider, make an appointment, be persistent. If you don't have healthcare, we have the Illinois Breast and Cervical Cancer Treatment Program, or IBCCP. You can find it online. You can find information about where to go to get an exam, and then they will send you to one of the participating facilities to get an exam, to get imaging and potentially a biopsy and see a breast specialist. So we have avenues out here where we can help you if you don't have health care insurance.
So we can no longer use it as an excuse.
Correct.
There are programs out here that can help you get it done for free and in a timely fashion, so you're not going to be delayed with getting these screenings done. We had another registered nurse that came on, Diana Berg. She came and she showed us how to do the proper breast exam. And the way that she does it is like, okay, we've been doing this wrong all along. And so I just encourage the ladies who didn't get a chance to see it is to go to my YouTube and pull it up, because the way that she demonstrated that breast exam, I know that a lot of us have been doing it incorrectly. And the way that she does it, you're bound. If something is there, you're going to find it. You're going to find it. And it also gives you a peace of mind, the way that she does it. It's so thorough. it gives you a peace of mind that when you do it, you know that at least for this month, I'm good. Now, if something happens when you get to the next month, get a piece of paper, draw 2 circles on it, and where you found it at, put a date. If it's lasting more than 3 weeks, then do something about it.
Yes.
Do something about it. And so I just appreciate her coming on to show us the proper way, because a lot of times we don't know.
Yes.
We don't want to ask the doctor when we go in and we're getting a clinical exam. She mentioned you get the clinical exam once a year. You get the mammogram once a year. You get your clinical exam once a year as well. But the 11 months, what are you doing?
Exactly. And again, just to reiterate on that, with the self-breast exam, once a month, and the best time is if you're having menstrual cycles, when you're putting your sanitary products away.
Okay.
That's how to think about it when the hormone levels have normalized and the breast become less tender or less lumpy and bumpy and your exam is more sensitive. If you don't have a menstrual cycle, then just choose the day of the month. It could be your birthday. But if you're gonna do it, the best way and the most sensitive test, is to do it every month. If you're not gonna be religious and do it every month, it's not as sensitive to pick up any changes, because your breast tissue, you have to get to know your breast tissue. If you have lumpy, bumpy breasts, if there's something in your breast that's new or different, you'll pick it up once you get to know your breast tissue. But if you don't know your breast tissue, it may be a little difficult to find something. So you're feeling for something new and different. While you're checking, any warmth, any redness, any spontaneous nipple discharge that comes out on its own. No longer do you have to squeeze the nipples.
And you know you're not breastfeeding.
Correct. Feel something new or different, you want to see your healthcare provider. So 3 keys to early prevention: the monthly self-breast exam, while we're in this topic, your screening mammogram if you're over 40. Now, if you have a strong family history of breast cancer, mom, sister, you may get your screening a little sooner, depending on when that person was diagnosed. So if my mom was diagnosed at 40, I should get my first mammogram at age 30, 10 years before. And I may even get additional screening with a breast MRI. It depends. It's not for everybody. It just depends on your situation. And then, of course, the clinical breast exam that's done by your healthcare provider is important.
Mm-hmm. So there's a lot of information that's been given on this show, and I'm trying to get to the comments. I hope I'm able to see it all. This comment is coming from Karen Freeman. She says, I have a cyst and was told by the doctor to go to the dermatologist to remove it. I went to the dermatologist who said, yes, it's a cyst that can be removed, but why cut on your breast if you don't have, I can't see the rest. If you don't have, why cut on your breast if you don't have it?
So when you say cyst, are we talking about a sebaceous cyst or epidermal inclusion cyst, which is like a pimple? So it's like a whitehead or a blackhead. Then those things we leave alone unless it's draining or it's infected. Then we will treat it with antibiotics or warm compress. Sometimes they heal, then they come back. We will remove the core when it's not bothering you, just to get rid of, if you don't want to be bothered with it anymore. So that sounds like a benign issue. If you want to see a breast specialist to take a peek at it, that's fine, but it sounds like it's okay that you're not removing it, especially if it's not bothering you. But if it continuously gets inflamed, you have to get antibiotics for it, it gets infected. Once it cools down and heals, then you can have it removed. They take the core out, so you don't have to worry about it.
Well, on here, Donna, she says, I can squeeze it and a lot of smelly pus.
Yes, so that's a sebaceous. So that's acne. It's like a pimple, basically. So I don't think you should squeeze, because sometimes it can cause scarring. Warm compresses are nice. Warm, hot compresses, let it just kind of open up and drain on its own. You could also see a breast specialist who would take care of it. Once it heals, then they can just take it out. If that dermatologist is not interested.
It drives her nuts. She said, okay, but it grows inside out. That was a good question here.
Okay, good question.
Wow. So at least she got her answer to the question. Yes. So see, like simple stuff like that can kind of like calm your nerves, and it can give you options on what to do about it. What is this? My survivor girlfriend said, thank you so much for all of the information that you provide on your live and all of the wonderful guests. Oh, absolutely. You know what? I try to bring on experts who know about the field. I could talk about it all day long, but this is someone who actually works in the field. She's one-on-one with the individuals in the field, so she can give you a first-hand, scenario as to what she's seen. And it's nice to have someone who's been in the front line, that's right up front, that can give you some accurate information. So I like that. So what we're gonna do is you can keep the comments coming, keep the questions coming. We're just gonna take a quick break and we're gonna listen to Charles Jenkins and This Is War. All right, so we're on break from radio station, but Facebook Live or not. Okay. All right, you guys, thank you for your questions and your comments. I appreciate all of you tuning in. Can you do me a favor? Can you like and share the video so that others can get this important information? Because we know there are a lot of African American women out here who needs to get a mammogram, who need to follow up with a mammogram, and who is just afraid because of the whole scenario. Someone may have had a bad experience and told them, girl, don't go, it's gonna hurt.
Yeah, so let's talk about that. So this is my spiel about the discomfort. So some of the myth, the mammogram, you do get some radiation. So you get more radiation flying in an airplane than you do from a mammogram. So it's minimal from a mammogram, okay? There's compression of the breast tissue. The flatter we get the compression, the more clear the abnormalities will show up on the screen. 15-20 minutes of some uncomfortableness that may be able to save your life is worth it. My hair hurt from my braids about 2 weeks from these braids. Oh my goodness. We get our eyebrows plugged. We get waxed. We do all these different things that may be uncomfortable. But the mammogram, that's a tool that we have that can potentially save your breast. The other thing about mammogram is it's a law now that we have to report the breast density. The radiologist has to report the breast density. So breast density goes from A to D.
Can you kind of explain what?
Okay. So breast density tells us how the picture will show up on the mammogram. So the mammogram is like an X-ray. So density A is fatty breast. So, postmenopausal, the hormones have gone. There are not all those thickened ducts that are being engorged from milk and all the hormone influence. So everything just kind of flattens out on the X-ray. It looks black. So you can see a white calcification and you could see a mass, which may show white. Density B, that's heterogeneous. So it's still a mammogram is a grade 2. You can see through it. When you have density C or D, that means instead of a black background, it's white. So imagine you trying to see a white calcification or a white mass. The sensitivity of the mammogram decreases. So the radiologist will report your breast density. And if you have breast density C or D, you may be eligible for additional screening with a whole breast ultrasound called an OBIS. And what we would do is order your screening mammogram, and then 6 months later, we'll get a whole breast ultrasound. So we have 2 tubes to check you with during the year, looking for any abnormalities. Another thing we have is tomosynthesis that we'll add to the screening mammogram. And what it does is it makes thinner slices through that dense tissue so that you can see things more clearly. So ask your healthcare provider when you get your mammogram, am I eligible for a mammogram with tomosynthesis or a whole breast ultrasound to further look at my breast if their density is C or D?
Wow. Now see, that's information that you just wouldn't know just going to the doctor. So no, that's good information because you can always rewind, play it back, and if you go to the doctor, we have to be more sensitive and read what they put on the papers. Read the information so you will know exactly what's going on with you if you have the dense breast or not, because most of us probably wouldn't know what that was if we heard the word. So you have to know what type of breast you have. And so we always talk about, touching ourselves. Don't be afraid to touch ourselves. We let other people touch us.
And ask questions.
Yeah. Ask questions. Touch yourself. Write them down before you go to the doctor. If you think you're not going to remember, or put it on a little recorder, or take somebody with you if you think you're just going to be out of it, that you're not going to remember. A lot of people go to the doctors by themselves, especially if you're going for a mammogram. Take somebody with you. I didn't take anybody with me because I really didn't think it was cancer. I just really felt like I was going to get a mammogram. But I didn't find out that day. I found out when a couple days later they called me. So, but I was in the room with the little gown on. You put your stuff in the locker. And then, you're sitting there with the other ladies and everybody is so quiet because nobody really wants to talk. So everybody's quiet. And then they come get you for the mammogram. And then when they send you back to the room, you're about to I had to get an ultrasound. So I'm like, okay, something's wrong. I'm getting an ultrasound. And then they said, we're going to schedule you for a biopsy all in the same day. I'm like, okay. So, I kind of knew something after I sat there for a while. And then a couple days later, the doctor called me on the phone to confirm it. And I was kind of ticked off that he called me on the phone.
I'm supposed to bring you in.
Yeah.
Yeah.
Is it common?
It's
like,
so we generally have the person that ordered the mammogram. So your healthcare provider, your physician, your PA, your nurse practitioner, whoever you have a relationship with.
Okay.
That's the person that generally orders the imaging. So instead of the radiologist, and in our institution, a lot of times the radiologist does the biopsy. Sometimes the physician, the surgeon will do it too. It just depends on the situation. If it's calcifications and it's something we can't feel, definitely the radiologist will do the biopsy. So the radiologist doesn't call the patient. Generally, we have that person that you already have a relationship call you. Say, these are the findings, but here is the plan. You have an appointment to see the breast specialist on this day. So we like to, when that provider calls the patient, there's a plan. And the person that calls can talk a little bit about it, but then say you're going to get more details when you go see the breast specialist, and the appointment is this.
Yeah, no, he just called and said, your test was positive for cancer, and he said the nurse navigator would be getting in touch with you.
Yeah.
And I had a really good nurse navigator.
Okay, we're back. We're going back.
All right, you guys, we are back. This is Lady ReShell with Warriors Talk, and we are talking about what Black women should know about breast cancer. And I'm sitting here with a registered nurse. She's an expert in this field. She's also passionate and an advocate as well. And so she's given us some life-saving information that we need to use for ourselves and also pass along to other women in our lives that we love. We have to make sure that we're doing our part. If you love someone, then you want the best for that person. So you're going to make sure that you're looking out for them just like you want them to look out for you. So we are learning some things that we can do and that we can control when it comes to reducing our risk of getting a breast cancer diagnosis. So we talked about controlling our weight. We talked about watching what we put in our mouths. We talked about talking to our family about our history. We talked about taking actions with our own selves and going to the doctor to find out what's going on with us. And also following up is a major thing that we need to do as well. And that we can eliminate the excuse of not having insurance, because we have programs out here that will be able to assist you even if you don't have insurance, and in a timely fashion, so you won't be waiting. So there's a lot of things that come into play when it comes to African American and breast cancer. We talked about the younger ones are being diagnosed more. There's a more aggressive, and also their mortality rate for some reason is low. And I don't know, I know they're doing studies about different ethnic backgrounds, different races. And we talked about, Donna and I talked about, before we got on, we talked about clinical trials and how we want to be present when they are putting together new medicines to treat individuals. We want our bodies, not our bodies, but our particular genes or whatever to be tested on, so the medicine can benefit us.
Right. Correct. So when patients come, even for their imaging, for their mammogram and their ultrasound, we're asking them to be a part of trials, to look at their imaging, compare their imaging with other women. Be proactive, accept it. It's anonymous, because the information we receive will benefit us. Unfortunately, African Americans, sometimes the women of color, are not so apt to agree to be a part of the study. The mindset of, oh, we're going to be used as a guinea pig. It did happen in the past, we know that, but we're asking you to be a part of the trial so that we can understand more the breast cancer that affects us, because a lot of the studies have been done on women, non-women of color, and so we want to know about ours. What is the biology of our breast cancer? So we ask you to participate in clinical trials, to look at your imaging. We ask for clinical trials to study your breast tissue so that we can compare and find therapies that will eradicate this cancer, keep it from coming back, and improve survival. We ask you to participate in clinical trials when it comes to treatment. And that's a wonderful thing. If you're eligible for a clinical trial, that means you're going to get the standard of care, which we have to give you, and plus or minus an additional therapy. And that additional therapy may be the key thing that we need to keep the cancer from recurring. So find out about the clinical trials, get a good understanding about it. And if your provider says you're eligible, then that's a wonderful thing. But not enough of us, women of color, consent to the clinical trial. So it limits the study or the information that we have about the biology of our tumor. And we know that all triple negative breast cancers are not alike. Their biologies are different. We pretty much know that Egyamycin, Cytoxan, and ACT, that's the standard. But your biology may respond to something different.
Yes.
Participating in the trials help us learn more about the biology of the tumor. And I want African Americans to have just as much input in that information.
And that's a way for us to have input. That's another thing that we can control. So I'm all about what can we control? What is in our hands that what we can do to help decrease us getting a risk of breast cancer? And not to mention that you're helping other individuals down the line who may get diagnosed with breast cancer. So you participating in these clinical trials, it's not only helping you, but it's helping those in the future as well.
Exactly.
So I want to read this comment. It says, I have a friend who had a mammogram, ultrasound, and biopsy, which was negative, but continuously bleeding from the nipple. No one has been able to provide an answer to her.
Okay. So when I think about nipple bleeding, my question is first, is it spontaneous? Is it coming out on its own without compression or stimulation? That's number one. Number two, she should get a second opinion, have another facility, read her imaging, read her ultrasound, check her biopsy, because nipple bloody discharge could be a sign of what we call a papilloma. Papillomas can be benign or cancer, or it could be a cancer. The reason for the second opinion is to make sure that they targeted the right place, because they should have put a clip in it. A clip is like a marker, so we know what area was biopsied. So get a second opinion of her imaging and her pathology from an academic facility. I'm at the University of Chicago Medicine, any academic center that has, mammography, great pathology that can review our information, and that will make me feel better with the situation.
Wow, I'm all about being persistent too.
Just to make sure.
Yes, just to give you a peace of mind, because if something like that is happening often, then it wasn't sit well with you. So evidently she is not sitting well with her because she shared the information. Correct. So I would get a second opinion, and it's okay to get.
It's okay to have someone else read your imaging.
Yes.
Our pathologist, wherever you would go, they would reread the imaging, not just take new pictures. Read your CDs, take additional pictures if they feel necessary, and also read the pathology. See if it's concordant. That area they biopsied, is that the area of concern, or was there something else?
And then it will give you a peace of mind, because two people done worked on it, two people done came up with the same conclusion.
Yeah, exactly.
And so you can get on it, whatever it is, you can take action with it. And so she also says, I believe in clinical trials. I was out in front of the center. What? I was out from and she was front and center when her oncologist asked her to.
Breast cancer.
I'm sorry.
I never heard of.
She was out front and center when her oncologist asked her he could send her some samples
Medullary.
out to San Francisco.
Medullary is rare, but it's a type of breast cancer, but it tends to be a more favorable breast cancer.
Favorable. What is that?
Favorable meaning the outcome is generally good. It's usually ER positive, HER2 negative. So,
I heard someone say the other day, the best type of cancer to get would be breast cancer.
So that goes to treatment. With breast cancer, we have multiple modalities we can treat it with. Multiple. The way your cancer is treated is dependent on the type of cancer. Is it non-invasive, like DCIS, inside the duct, that doesn't travel, that doesn't spread? Or is it an invasive cancer? There are different types of invasive cancer. We have multiple ways we can treat it. I think that's why finding it early is so important, because we want to find it early when you have options versus, we can only give you this, we can't cure it, but we can just give you something to make it comfortable. No. So multiple modalities. Surgery, we can treat with radiation. It depends on your situation. We can give chemotherapy. We can give targeted therapy, which is like Herceptin, or we can give endocrine therapy. It depends on your type of cancer and the characteristics of that cancer to decide on the treatment. So with all those different modalities and your follow-up, coming for your exams, all those things can improve survival.
So when we talk about the survival rate, so there's different things that go into play. with you being a survivor, because like you said before, everybody breast cancer is different. Even if you had the same type of breast cancer, the treatment may be a little different, because we don't look at what if somebody has some type of problems beforehand. Say if you have diabetes or you have high blood pressure, so there's other things that are going into play while you're getting that treatment that could maybe cause it to go one way or the other. And I think people don't look at that as well when they're kind of comparing to one situation to another.
Yeah, so like looking at the biology of the cancer, looking at the grade of the cancer, the Ki-67, which looks at proliferation, how fast are the cells growing. You may be eligible for an oncotype, which is a genomic test, where we send your specimen out to look at the tumor to find out what your risk score is. So there's so many different things, and that risk score may help decide whether you're eligible for a trial or you get chemo or no chemo or chemo and endocrine therapy. So there's so many things out there. Listen, ask lots of questions, take notes, write it down. Don't say, oh, my friend had a stage 1 breast cancer or stage 2 and those were effective. She got chemo up front. Everyone's treatment plan is individualized. We try to individualize it as best we can.
Yeah, that was my question to my doctor was, she was like, well, my team met, and, you know, we went over your case, and this is what we came up with your treatment. And I'm just like, okay, why do I have to do, because I had to do the chemo first and the surgery generated. I'm like, well, why do I have to do this first? I know people that do surgery first. Why can't I? And she was like,
study the biology of the cancer to find out how it's going to respond. Because if we had taken the tumor out first, we can give you ACT or whatever chemo they gave you, but how do we really know it's working?
Right.
We know it's working because we can measure it by doing an exam, doing an ultrasound to find out how you're responding.
Yes. And there was, I think I had like maybe my second chemo, and she couldn't even feel the lump anymore. She was like, I can't feel it, so I'm not going to examine you anymore. It's not there. And so, you know, just listening to her, because you have to have somebody that you trust and that, you know, you have that relationship with, and that you're not afraid to ask questions.
Correct.
To the fear that you may have. Because she told me that it was another young lady that was 33, and me and her had the same diagnosis, and not that our background was the same, because I was 43 and she was 33.
Yes.
And they gave us the same treatment plan, but she didn't do it, and she passed on. So it just depends on, you know, it depends on you, and I had to pray, and I had to get direction from God to say, you know, should I do this? Because a lot of people try to throw your faith in there, and they'll say, well, why are you doing chemo? You don't trust God to heal you? And I'm like, God created all things. He created these doctors that's able to create this medicine that can heal you. So why would we let all of this go to waste? And even if they put the medicine in you, God is still in control to allow it to do what it's supposed to. And so you have to quiet all that noise.
Correct. The counseling piece and your mental health is just as important as taking the medication, doing the surgery, following up on your radiation, going every day, 6 weeks.
Yes.
It's just as important. So when patients come in and we talk about, here are the steps, okay, then the next thing I ask, because sometimes patients are afraid to tell you that I really don't think I can handle this, or I don't have anyone that I can trust and talk to. So we have a psych-oncology group a psychologist, psychiatrist who talk to our patients, and we have in-house support groups. So we have to offer that to our patients. Sometimes we forget, but it's just as important. Patients may say, oh no, I got it. I said, well, just go one time and just try to make a relationship with that person. It's a great thing if it works. If you're okay, then that's fine. The other thing is looking at the patient's fertility status. They may be in their 30s and have never had a baby. And so you're going to give them chemo, put them in menopause. They may not. So they may be someone you want to see the gynecologist that does the fertility to free some of those ovums ahead of time to store. So post-treatment, she can still retrieve her ovaries and potentially have a baby if she likes. So those are things that we have to think about to share with our patients. And either they have children, but they want others. Right. Because,
I'm glad you said that. Because my guest that was on here last week, she was 25 when she found her cancer. And they didn't give her the option of freezing her eggs. They wanted to just hurry up and treat it. And she said, you know, I felt so bad because I wanted to have babies. What, you know, why can't we just take that extra step to preserve her eggs and you know, I don't know.
Sometimes the fertility returns, but it's a good thing to do ahead of time. And there's sometimes insurance issues in their programs. The Living Strong program does help financially with some of the retrieval costs.
Oh, okay.
Living Strong, if you're interested, but your doctor will provide us for fill out the paperwork, which we do, to help get you financial assistance for that.
Wow. I hope you guys are enjoying this. This is a lot of information, but it's very helpful. And like I said, Donna is out front and center in the community. And the one thing that I like that she does that I am going to try, I will be a part of, I ain't going to say try, I'm going to take action. She teaches Zumba. And she has an event coming up, and I want her to talk about the event really quick because I'm excited about it. She's actually giving back to the cancer community. And so I said she's passionate about it. This is what she does. And so she's going to tell you all about what she does.
Hi. Okay. So every year I have a fundraiser to give money back to a support group. And so this time we're giving money to Sisters Working It Out, Cancer Awareness and Health Advocacy Organization. So the event is November 3rd. It's from 10 a.m. to noon. It's going to be at Price Elementary School Gym, 4351 South Drexel. Myself and 3 other trainers will be demonstrating fitness. So it's for all ages. It's $10, and the funds will be going to Sisters Working It Out. Anyone from beginners, all levels of fitness, you're welcome to join.
Awesome. I think it's going to be an amazing event. If you haven't started out being active, this is a great start, and it's for a good cause. So come on, get on board. And Sisters Working It Out is one of my sponsors, so I'm excited. Okay. So, Donna, give us some words of wisdom to African American women. And we already gave all information what they should know about breast cancer, but we want to give them some information. Some of your words of wisdom that you've been wanting to say.
I think the most important part is just to not be afraid. To don't think that any question is a dumb question. If it's a question in your mind, then it's a question worth asking. That's most important. And I keep going back to the clinical trials because we want our tissues studied so that we can find out what helps us so that we can change this mortality and disparity of women of color. Again, just get your mammogram if you're of the age of mammography. If you feel something new or different, we'll order the proper screening tool. Tell your provider if you feel something new or different in your breast. Talk to your family about your health history, about the family history. Learn your family history so that you can find out your personal history. Add exercise to your routine. It can be hula hooping. So every commercial, grab that hula hoop. It can walk up and down your stairs. Limit alcohol. Limit the taking of menopausal hormones like hormone replacement therapy for hot flashes. Try not to use those. There are other non-hormonal products that you use. If you can breastfeed, do it. That's helpful. And share this information with others.
Yes, I love that. Thank you so much. How can they follow you on Facebook or follow you for the Zumba class?
So Donna Christian-Harris is my name on Facebook.
Yes, thank you so much, Donna.
Thank you for having me.
I'm excited. I hope you guys enjoyed the show. Please like and share this show with all the people in your life that you love, and worries you already know what to do. Keep thriving while surviving.
Thank you.
Yes. Yes, Facebook. Thank you so much. I'm gonna post Donna's flyer on my page so you guys can come and you can join us because I'm gonna go. Because I need to get active. Yeah, I need to do more things. So I appreciate you guys for listening in. I appreciate all of the comments. I hope that you guys are walking away with some knowledge that you can use and you can put to action. So thank you guys so much, and we will see you next Monday.
Thank you for having me.
You're very welcome. See you guys.